if you look at what does the literature tells us regarding the factors which have been associated with this soft tissue recession around the implants, you don't have so many studies, so many data to say for sure which is the reason for. Let's say that for sure bad implant installation is the most important, it's most frequent factor associated with the development of soft tissue dehiscence. And this bad implant position regards the oral fascial position of the implant shoulder, which means that most of the time is the angulation of this implant that is wrong. And this is very, very frequent in the situation in which the implant is placed in the immediate post-extraction socket, because the tendency obviously is to displace our implant head in a more palatal position with respect to the socket and to use too long implants. As much as you increase the length of the implant, you risk that instead of using the bone crest that is quite vertical, you have to use the cranial bone that is more palatally displaced. And so if you place the most apical extension of your implant too much apically and too much palatally, the problem is that the implant shoulder gets out too much buccally. And so this too much buccal displacement of the implant shoulder is maybe the most frequently associated aspect with the development of gingival recession, and this is completely independent on the presence of bone or not, because obviously if the shoulder is too much buccally, maybe you don't have buccal bone enough covering the implant shoulder, but it means that the suprabony component of the implant, the abutment, is even more buccal. And so there is no way for the soft tissue to be thick enough to cover something that is so buccally displaced. So this is the main reason why soft tissue dehiscence forms, and also why there is a high risk of also implant surface contamination, because we don't have buccal bone, and together with gingival recession, this creates the condition of implant surface contamination due to the exposure in the oral cavity. As I was telling you, also the depth of the implant platform, which means you place the implant too much apical, and the angulation of the implant fixture are always factors that can create the condition which favors the soft tissue dehiscence to form. If you place your implant, your implant platform, instead of placing only 3.5 millimeters with respect to the soft tissue margin, you place it 5 millimeters apical. It means that the bone starts 5 millimeters more apical with respect to the soft tissue margin, and not only 3. It means that you need soft tissue thickness so thick, not only for 3 millimeters, but for 5, which is even more rare than having this soft tissue thickness enough for 3 millimeters. As much as you displace your implant in apical direction, this creates much more favorable condition for gingival recession to start, because the bone, which is the main factor that protects gingival recession, is even more apical. So it's completely absurd, and it's so absurd that for many, many years, it's incredible that for many, many years, it has been suggested that in the aesthetic zone, the implant must be placed more apically. It's absurd. As much as you place your implant apical, there is a greater risk of gingival recession, because you have a wider, higher zone that is protected only from soft tissue and not with the bone. So this is exactly the opposite. So you should place your implant platform less apical as possible in order to reduce the area that is only protected by soft tissue in relation to the risk of gingival recession to form. Obviously, the biotype is one of the main factors associated with the development of soft tissue dehiscence. And soft tissue dehiscence is much frequent in a thin biotype than in a thick biotype. And this is very easy to understand. The problem is what is thick and what is thin. Because we cannot consider 1 millimeter or 1.5 millimeters as we are used to consider the borderline situation as it is for teeth from a thin to a thick biotype. Because 1.5 millimeter cannot be considered thick enough for the risk of gingival recession around implant, because it means that if the biotype is 1.5, the connective tissue is 1.2, 1.3. And so the inflammatory process can occupy the whole area of connective tissue, and so gingival recession form even if the thickness is only 1.5. So for sure, we have to change this limit of the thin and thick biotype and put the number that I think is critical to at least 2 millimeters. So I can tell you that the thick biotype is a biotype that is thick enough once the thickness of it is at least 2 millimeters for 3.5 millimeters height. And this is very rare that you can find in human beings, I mean, such a soft tissue thickness in the healthy situation. Every single biotype that is less than 2 millimeters are at risk. And obviously, if it is even thinner, the risk is even greater. But we cannot consider thin and thick biotype with the old parameter of 1.5, because this is not enough for implant, and I think that the good parameter should be 2 millimeters. When I will show you the, let's say, my personal, absolutely my personal, let's say, treatment options and diagram of the different treatment options according to the type of tooth extraction, dental or periodontal, I will tell you that the thickness of the soft tissue is a critical aspect to select the surgical approach, but it's even more true that some procedure which we consider very important for preserving bone thickness, like socket preservation, does not give any true help in terms of increasing the soft tissue thickness. Because if you extract a tooth, yes, and you fill this socket with bone filler materials, you don't give the soft tissue any way to increase in thickness. So maybe you preserve the right thickness of the bone, preventing the soft tissue to collapse in the area of the bone, but it's also true that you don't give any space for the soft tissue to grow in thickness, which can be achieved on the opposite side if you don't fill the socket. So if you don't fill the socket, I absolutely believe, even if we don't have data on this, that there is a greater space that can be occupied by the connective tissue of the soft tissue in the area that can be also bone, so that the possibility to increase the thickness of the soft tissue is much more if you don't make any socket preservation. As much as you fill this socket with bone filler materials, you may increase and you may keep the right thickness of the bone, but you don't allow the soft tissue to increase in the thickness. So if you make a socket preservation, it's a good solution maybe for the bone. You have enough bone to place your implant, but this does not mean that when you are going to place your implant, you have the right soft tissue thickness. And so if you make socket preservation, when it is the time to place the implant, most of the time you have to make soft tissue augmentation, because you have to increase the thickness of the soft tissue more than 2 millimeters for at least 3.5 millimeters, because you did not allow, with socket preservation, the soft tissue to increase in the thickness. Maybe if you leave the socket heal by itself, yes, you don't have the same amount of bone, but you have a greater thickness of the soft tissue, because this space can be occupied by the soft tissue. And so, yes, during implant installation, maybe you have to make some bone augmentation, but you don't have to make soft tissue augmentation. So I'm not sure that it's always better or easier to make soft tissue augmentation or bone augmentation. But it's not said that by making socket preservation, everything is finished. It's exactly the opposite. In the aesthetic areas, if you don't leave the soft tissue increase in the thickness, you never have spontaneously a soft tissue thickness that is equal or greater than 2 millimeters for 3.5 millimeters. So we have to also to understand what is the advantage of socket preservation when we have to make our decision-making process of what to do at the time of tooth extraction. And this is what we are going to speak about for sure when I will show you my treatment choice selection. The presence of keratinized tissue. This is a very important concept. Most of the implantologists now is absolutely aware of the importance of keratinized tissue, and I agree on this, that keratinized tissue is important, because keratinized tissue, it's a very hard tissue, collagen dense, and with keratinized epithelium. And so when the patient feels the presence of keratinized tissue, it can brush more effectively. And so I absolutely believe that the keratinized tissue is important to improve removal of plaque, better oral hygiene. But in terms of risk of gingival recession to form around implant, the presence of keratinized tissue height is not enough to be considered, because height doesn't mean thickness. Do you understand? So keratinized tissue, for sure, is nice. For sure, it is better for the patient to clean. It's critical, I believe, in the posterior area where you have much more problem for the patient to clean effectively. But when we speak about aesthetics, when we speak about risk of gingival recession to form, we have to speak about the thickness of the keratinized tissue, which is critical. So if you have keratinized tissue, like here, you may have 3 millimeters or 4 millimeters, or even here, you may have 4, 5 millimeters of keratinized tissue. Is this enough to prevent gingival recession to form around the implant-supported crown that will replace this tooth? No. It's nice that it's keratinized tissue because the patient can clean better, but it's not enough, because if this keratinized tissue has a thickness that is less than 1.5 in the presence of toothbrushing trauma or in the presence of subgingival plaque formation, this is going to recede, because gingival recession does not depend on the tissue if it's keratinized or not, but it depends on the thickness of the connective tissue that is invaded or not by the inflammatory process. So please don't consider the presence of keratinized tissue as enough to protect your implant from gingival recession to form. This is going to recede exactly in the same way of a tissue that is less keratinized if it is not thick enough. So the critical aspect is not the presence and how much keratinized tissue do you have. That's important for aesthetic. That is important for toothbrushing, but it's not enough to prevent gingival recession to form. You have to consider what is the thickness of this keratinized tissue. And if I have to replace this tooth with an implant, I need that this keratinized tissue that is more than 2.5 millimeters in height, so it's nice, very nice for the patient to clean, should be at least 2 millimeters thick in order to prevent gingival recession to form. Other factors that have been associated with gingival recession around the implant in the literature are all concerning bone, which means that in the literature it seems that the most important factors to prevent gingival recession to form or to favor gingival recession is the presence or not of the buccal bone. And according to me, this is not completely correct. I mean, the presence of bone lesions, absence of the buccal bone protecting the implant surface, for sure it's something that is favoring gingival recession and implant exposure if we don't have enough soft tissue thickness. That is critical, because if we have bone lesions, yes, but if we have enough thickness of the soft tissue, who is going to realize that there is no buccal bone? Because gingival recession starts from the soft tissue margin, and buccal bone starts 3.5 millimeters more apical. So there is no way to realize that there is a bone lesions if there is no gingival recession. But gingival recession depends on the presence of the soft tissue thickness. So I would like to see in the future what happens to all my clinical cases in which the bone is not intact at the buccal aspect because there is some small bone lesions, let's say 2 millimeters of bone lesions, 1.5 millimeters of buccal bone lesions, but there is no gingival recession. Why there is no gingival recession? Because I personally made soft tissue augmentation during implant installation. So the thickness of the soft tissue is more than 2.5 millimeters for more than 3.5 millimeters, and there is no intact bone. But who is going to realize that there is no intact bone? There is no gingival recession. You have to make a cone beam. But why do you have to make a cone beam if the patient is perfect? If the patient does not have any gingival recession, if the soft tissue margin is in the right position, why do we have to make a cone beam? The literature tells us that most of the time the presence of anatomic bone lesions around the implant is something that we can realize because we made the cone beam for other teeth, for our area, and so it's something that we could not think that there was really a gingival recession, something that we was not expecting. Why? Because there is no gingival recession. So the presence of anatomic bone lesions, yes, I agree, it's something that can favor the appearance of gingival recession once if there is not enough soft tissue thickness. So buccal bone lesions, the absence of buccal bone is very negative factors, and maybe it's also something that can influence the long-term success of the implant if gingival recession form, so that the implant surface contaminated will be exposed. But if there is no gingival recession, I don't see why the presence of buccal bone lesions can be a problem for the patient. Obviously, I'm speaking about shallow buccal bone lesions, not that there is complete lack of the buccal bone, because this can also jeopardize maybe the stability of the implant, the risk of transparency of the metallic surface through the soft tissue, etc., etc. So, in my opinion, it's my personal opinion, the importance of the buccal bone has been maybe exaggerated in terms of critical factor to prevent gingival recession. Since gingival recession starts at the level of the soft tissue margin, it is more critical to have the right thickness of the soft tissue than the right thickness of the bone to prevent gingival recession to form. While in the literature you can see that there is a lot of publications that speaks about the presence or not of the intact facial bone crest and the thickness of this bone at the buccal aspect of the implant as critical factors to prevent gingival recession that really I don't be so sure, because they consider the gingival recession around the implant is when there is implant exposure, and obviously implant exposure there is only if there is no bone. But the problem starts much more corner and much more early. About other aspects that are not so frequently mentioned in the literature as factors favoring the development of gingival recession around implants are the level of the bone at the level of the adjacent teeth, the first bone-implant contact, which means how apical you place the implant. I think this is very important. If you place the implant too much apical, you increase the soft tissue area, and so there is much more risk that gingival recession, because gingival recession depends on soft tissue for a longer, higher area with respect to where can happen if you place your implant in the right position with respect to the soft tissue margin of the adjacent tooth. Regarding the interproximal bone crest at the adjacent tooth, obviously it's something that gives support to the papilla area, gives support to the soft tissue, and so this is also a critical factor for gingival recession to form at the buccal aspect. The defect of the facial bone, I have already spoken to you about this concept. The implant, the metallic surface starts about 3.5 millimeters with respect to the soft tissue margin of the adjacent tooth. So I will have recession and exposure of this implant surface only if this area belonging to the suprabony component of the implant and to the transmucosal portion of the implant will be already exposed. And the exposure of the soft tissue from this ideal position to the implant surface depends only on the soft tissue and not on the bone at the buccal aspect of the implant. Two factors that are very critical for me, even if we don't know exactly what is the role of these factors in the development of gingival recession, is the implant diameter. Why the implant diameter is important? I think that the implant diameter in all these studies that have been published is considered important, because as much as you increase the implant diameter, the less is the possibility to have buccal bone. Always, the literature always think about the bone. I think that if you have the big diameter of the implant, there is a greater diameter of the suprabony component of the implant, unless you use like a platform switching system, but very, very platform switching, in which you reduce a lot the suprabony component of the implant with respect to the implant diameter, because as much as you increase the diameter of the suprabony component, which means abutment of the implant, the greater is the risk is not to have enough soft tissue thickness to protect gingival recession to form. So the diameter of the implant is important for the bone, and this is important, but the suprabony component, the diameter of the suprabony component of the implant, we can call it abutment, just to speak in general term, is even more important than diameter of the implant to protect gingival recession to form, because again, gingival recession does not start at the level of the bone, but starts 3.5 millimeters more corner. While regarding smoke, I have to tell you that when I speak about smoke and when I speak about implant, I don't want to hear the term smoking habit. So in my opinion, you should not place implants in heavy smoker at all. I'm not speaking about patients smoking more than 20 cigarettes. 20 cigarettes is somebody that you don't have also to consider in general in terms of implant therapy, because it's a failure, for sure. Before and after, it's a failure. But it's also, in my opinion, extremely risky to place implants in patients smoking between 10 and 12 and 20. Because when the patients say, I smoke 13, 14, most probably it smokes 20. When the patient say smoke 10, most probably it smoke more than 10. If the patient really smoke less than 10, it writes 3-4 cigarettes a day. And this is true. If there is patient, because I was a very light smoker in the very, very past, and I was smoking 2-3 cigarettes a day when it was at the stadium and my football team was losing. This was the only occasion in which I was, let's say, a smoker. So if one is a smoker, most of the time he smokes around 10 or more than 10, and you cannot consider this a good candidates for implant therapy. You have to insist with this patient that you are going to place the implant only if they stop smoking. Stop smoking means that you don't have this burning effect of the smoking habits on the soft tissue. You don't have the vasoconstriction, which does not give blood supply to the soft tissue to heal. You don't have the typical bacteria, which are more anaerobic in the presence of the heavy smoker inside the pocket with respect to the patient that does not smoke. So the main reason why you have to tell your patient you have to stop smoking is not because of the general problem, which is even more important, as you know, in general health, in terms of smoking, relationship, and diseases, smoking and reduce of the immune system. It's very, very critical that the patient know that she or he has to stop smoking in order to reduce the local effect of the smoking habit of the oral cavity, which means much more blood supply to the soft tissue, which means more possibility for the soft tissue to heal, and different temperature, pH inside the pocket, which means different type of bacteria. And so the patient must stop smoking, and you have to ask the patient, please stop smoking during, before, and after my implant therapy as long as you can if you want to increase the predictability of success of your implant therapy. And once they stop smoking, you have to take the occasion to try to convince them to smoke, to stop forever. But you don't have to ask to a heavy smoker, you have to stop for the life, because it's not possible for this guy to think that something that he has used to doing for 40 years, 20 cigarettes a day or 15 cigarettes a day, he has to stop in one day, and then he cannot stop smoke anymore. You have to try to make him understand that it's something that she or he has to do for the time you need, for the soft tissue and the hard tissue to heal. And then, since it is 4 months, 3 months that the patient does not smoke, you have obviously to convince him that this is the right moment for you to stop to smoke forever. So in my way of making implants, I don't make implants at all in smoking, heavy smoking patient. I absolutely pretend they stop smoking before, let's say 15 days, 1 month, even better, before the therapy, not to smoke during the healing, and not to smoke during the phase of osteointegration that I tell them it lasts longer, even if it's not true, to convince them that they have to stop for a longer time of period. I don't insist at the time of the implant that they have to smoke, to stop forever, because for this patient sometimes it's not acceptable. Treatment of implants, which means coverage of implant, anesthetic implants, even less predictable. I absolutely believe in smoking patients, so I don't propose the treatment that I'm going to share with you in the next hours in smoking patients.